A patient's family member insists you give them detailed information about the patient's condition, but the patient has not consented to this. What would you do?
I would first acknowledge the family member's concern rather than dismissing it, since worry usually comes from love and fear rather than bad intent. I would explain calmly that I am not able to share clinical details without the patient's permission, and that this is about protecting the patient's rights rather than being unhelpful. Instead of leaving it there, I would offer a constructive next step, such as asking the patient directly whether she is comfortable including that relative in a conversation with the doctor. If she agrees, I would arrange a joint discussion so the family gets the reassurance they need while the patient's autonomy stays intact. If she refuses, I would gently explain to the family that I have to respect her wishes, while still offering general reassurance about her care where appropriate. This approach avoids confrontation and keeps trust with both sides. Confidentiality situations like this come up often on busy wards, and I have found that offering an alternative path forward, rather than simply saying no, resolves most of the tension almost immediately.
You are alone on the ward and two patients need urgent attention at the same time. How would you handle it?
I would quickly assess both patients, even briefly, to judge which one is at greater immediate risk rather than assuming the first alarm is the priority. If one patient's situation is clearly life-threatening, such as a possible airway problem, and the other is uncomfortable but stable, I would attend to the higher-risk patient first while calling for help through the nurse call system or a colleague nearby. I would ask a healthcare assistant or any available staff member to sit briefly with the second patient and reassure them that I will be there shortly, rather than leaving them feeling ignored. Once the urgent situation is under control or additional staff have arrived, I would move to the second patient without delay. I would also document both situations clearly afterward, including timings, since accurate records matter when two urgent events overlap. This kind of moment tests a nurse's ability to triage under pressure, and I rely on structured clinical judgment rather than panic, because clear prioritization, even in seconds, genuinely changes outcomes for both patients involved.
A doctor prescribes a medication dose that you believe is unsafe for a specific patient. What would you do?
I would not administer the dose until my concern was resolved, since patient safety always comes before simply following instructions. I would first double-check the patient's chart myself, looking at relevant results such as kidney function or allergies, to confirm whether my concern was clinically justified. I would then contact the doctor directly and explain specifically what worried me, referencing the actual figures rather than a vague feeling, since doctors respond better to precise clinical reasoning. If the doctor agreed, I would wait for the revised order before proceeding. If the doctor insisted the dose was correct and I still felt uneasy, I would escalate the concern to my nurse in charge or a senior colleague, as our escalation policy exists precisely for this situation. I would document the entire conversation clearly regardless of the outcome. Raising a concern like this is not about questioning a doctor's competence, it is about acting as a genuine safety check within the team. A good working relationship with doctors depends on this kind of respectful, evidence-based communication, not silence.
During a busy shift, you realize you forgot to give a scheduled medication on time. What would you do?
I would first check on the patient to make sure there was no immediate harm from the delay, since patient well-being always comes before paperwork. I would then inform the doctor or pharmacist promptly, explain exactly what happened, and ask whether the dose should still be given late, adjusted, or skipped, rather than making that clinical decision myself. I would follow whatever guidance they gave and administer or withhold the dose accordingly. I would also report the incident through our formal reporting system, since transparency matters more than trying to quietly correct it and move on. I would speak honestly with my supervisor about what led to the delay, whether it was workload, distraction, or a system issue, because identifying the cause helps prevent it happening again. I would not try to hide the mistake or downplay it to avoid difficult conversations. Nurses are human, and errors happen under pressure, but what defines professionalism is not the mistake itself, it is acting quickly, honestly, and putting the patient's safety ahead of personal embarrassment the moment something goes wrong.
A patient refuses a necessary treatment and becomes upset when you try to explain why it matters. What would you do?
I would slow down rather than repeating the same explanation more firmly, since patients who refuse treatment are often reacting to fear rather than genuine disagreement. I would sit with the patient, ask what specifically was worrying them about the treatment, and listen without interrupting before responding. Once I understood the real concern, whether it was pain, a past bad experience, or simply not understanding the risks of refusing, I would address that specific worry directly rather than giving a generic medical explanation. I would explain, in plain language, what could happen if the treatment was skipped, while making clear the final decision remains theirs. If they still refused after a genuine, informed discussion, would respect that decision, document it clearly, and inform the doctor so alternative options could be considered. I would never pressure or argue with a patient into compliance. Respecting autonomy while making sure the refusal is genuinely informed, rather than based on fear or misunderstanding, usually leads to a better outcome than insistence, and it preserves the patient's trust in the whole care team.
You notice a patient's condition is subtly worsening, but their vital signs are still technically within normal range. What would you do?
I would trust that subtle change rather than dismissing it simply because the numbers still look acceptable, since early deterioration often shows up in behavior or trends before it shows up clearly in a single reading. I would repeat the patient's observations sooner than scheduled and calculate their early warning score to see if a pattern was emerging. I would also ask the patient directly how they were feeling, since patients often notice something is wrong before it becomes measurable. If the trend confirmed my concern, I would escalate to the doctor immediately, describing the specific change over time rather than just the current numbers, since trends are often more persuasive than a single reading. I would continue monitoring more frequently until reviewed. I would not wait for the next scheduled round if my instinct told me something was off. Nurses spend far more time at the bedside than doctors do, which means a nurse's judgment about a patient, just not looking right, deserves to be acted on quickly rather than second-guessed or dismissed as overreaction.
A patient suddenly collapses and stops breathing while you are alone with them. What would you do?
I would immediately call for the emergency response team using the ward's alert system while starting basic life support myself, since even a few seconds of delay in beginning compressions can affect the outcome. I would shout for help rather than leaving the patient to search for assistance, so someone could bring the emergency trolley and defibrillator while I continued care. Once colleagues arrived, I would clearly hand over what had happened and continue whichever role was needed, whether compressions, ventilation, or preparing equipment, until relieved. I would make sure someone was tracking timings and interventions accurately, since precise documentation matters both for ongoing treatment and for the debrief afterward. I would stay involved until the patient was stabilized and safely handed over to the appropriate team, such as intensive care. Afterward, I would take part in the post-event review honestly, reflecting on anything that could improve response time. In an emergency like this, acting instantly on trained protocol rather than hesitating or waiting for someone senior to arrive is what genuinely protects the patient.
You are asked to care for a patient who does not speak your language and has no family present. How would you manage this?
I would arrange professional interpreter support as early as possible rather than relying on guesswork or informal communication, since language barriers around symptoms and consent are a genuine safety issue, not just an inconvenience. While waiting for interpreter access, I would use simple gestures, translated symptom charts if available, and slow, clear speech to check on basic comfort and needs. I would avoid making assumptions about what the patient wants or feels simply because verbal communication is difficult. Once interpreter support was available, I would use it for anything involving consent, symptoms, or decisions, rather than trying to shortcut the process. I would also check in more frequently than usual, since a patient without family present and without shared language can feel especially isolated and anxious. I would document clearly whenever interpreter services were used and what was communicated. This kind of situation requires patience and proper resources rather than improvisation, because misunderstandings around consent or symptoms can have serious consequences, and every patient deserves the same quality of communication regardless of language.
A colleague asks you to falsify or backdate a chart entry to cover a missed task. What would you do?
I would refuse clearly but respectfully, since falsifying documentation is both a professional and legal risk that affects patient safety, not just a shortcut to avoid paperwork trouble. I would explain to my colleague that an honest late entry, clearly marked as such, is acceptable, while a backdated or falsified one is not, and I would encourage them to correct it properly instead. If they were reluctant or the missed task had potential consequences for the patient, I would encourage them to report it themselves, and if necessary, I would raise it with the nurse in charge to make sure the patient's safety was addressed regardless of the paperwork issue. I would not agree simply to avoid an uncomfortable conversation with a colleague. I understand the pressure that leads people to consider shortcuts like this, especially during exhausting shifts, but protecting accurate records protects patients long after that shift ends. Integrity in documentation is one of the areas where a nurse cannot compromise, no matter how much easier it might seem at the moment.
A patient's family is unhappy with the level of care and threatens to file a complaint. How would you respond?
I would take their concerns seriously rather than becoming defensive, since a complaint usually signals a genuine gap between what the family expected and what they experienced. I would ask them calmly to explain specifically what had gone wrong, listening fully before responding, rather than assuming I already knew the issue. If there was something within my control that I could address immediately, such as clarifying a misunderstanding or adjusting care, I would do so on the spot. I would also make sure they knew how to raise a formal complaint if they still wished to, since patients and families have every right to do so, and I would never discourage them from that process. I would inform my nurse in charge or manager about the situation so it could be followed up properly, rather than trying to resolve everything alone or hoping it would pass quietly. Treating a complaint as valuable feedback rather than a personal attack helps de-escalate the immediate tension and often improves care for the next patient in a similar situation.
You are assigned more patients than you feel you can safely manage during a shift. What would you do?
I would raise the concern immediately with my nurse in charge rather than trying to quietly manage an unsafe workload alone, since patient safety depends on honest communication about capacity. I would be specific about why the assignment felt unsafe, whether it was the acuity of certain patients, the number of scheduled procedures, or lack of support staff, rather than simply saying it felt like too much. While waiting for a possible adjustment, I would prioritize patients based on clinical risk, grouping tasks efficiently and delegating appropriate work to healthcare assistants with clear instructions. I would communicate openly with colleagues about what still needed attention, so nothing was silently missed. If no additional support was available, I would focus on keeping every patient safe rather than trying to complete every non-urgent task perfectly. I would document honestly if certain lower priority care was delayed due to workload. Raising staffing concerns early, rather than suffering silently through an unsafe shift, protects both patients and the nurse, and it also gives management the information they need to address the problem properly.
A patient is nearing the end of life and the family is struggling to accept it. How would you support them?
I would focus on creating a calm, private space for the family rather than rushing them through the situation, since grief needs room rather than efficiency. I would make sure the patient's comfort, particularly pain and breathing symptoms, was actively managed so the family could focus on being present rather than worrying about visible distress. I would speak to the family honestly about what to expect, gently rather than clinically, and give them time to ask questions without feeling hurried. I would check on them periodically without intruding on their private moments together, offering small practical support such as chairs, privacy, or contacting a chaplain or counselor if they wanted one. If they were struggling to accept the prognosis, I would not argue with their hope, but I would make sure the medical team communicated clearly so no false expectations were created. After the patient passed, I would give the family time alone before necessary procedures and point them toward bereavement support services. End-of-life care is as much about the family's experience as the patient's comfort.
A newly qualified nurse on your team seems overwhelmed and hesitant during patient care. What would you do?
I would approach them privately rather than pointing out their hesitation in front of patients or colleagues, since confidence grows better in a supportive environment than an exposed one. I would ask them directly what specifically felt overwhelming, whether it was a particular skill, the pace of the ward, or simply unfamiliarity, rather than assuming the cause. For practical tasks they were unsure about, I would walk through the steps alongside them a few times, explaining the reasoning rather than just demonstrating, then gradually let them take the lead while staying nearby for support. I would give specific, genuine praise when they did something well, since new nurses often notice their mistakes far more than their progress. I would also check in with them regularly over the following weeks rather than assuming one conversation fixed everything. If their struggles seemed to affect patient safety in the moment, I would step in immediately without hesitation, but framed as teamwork rather than criticism. Building a new nurse's confidence takes patience, and a calm, encouraging approach usually works far better than correction alone.
Your hospital suddenly changes a major policy or procedure with very little notice. How would you adapt?
I would focus first on understanding exactly what changed and why, rather than resisting simply because it was unfamiliar, since most policy changes exist for a genuine safety or efficiency reason even if the timing feels inconvenient. I would identify the safety-critical elements of the new process first, making sure those were followed correctly even if I was slower with less urgent parts initially. I would ask questions openly if something was unclear rather than guessing, and I would pair up with a colleague who understood the change more quickly so we could support each other in real time. I would keep patient care as the priority throughout the transition, accepting that some tasks might take longer during the adjustment period. Once I felt confident, I would help other colleagues who were still struggling, since a team adapts faster together than individually. I would also give honest feedback afterward if the rollout process itself could have been smoother. Sudden change is uncomfortable, but protecting the essentials first and leaning on the team makes the transition far less disruptive to patient care.
You suspect a patient may be a victim of abuse or neglect at home, but they have not said so directly. What would you do?
I would document the specific signs I noticed factually, without jumping to conclusions, since suspicion needs careful and objective observation rather than assumption. I would find a private, calm moment to gently ask the patient open-ended questions about their home situation, giving them space to share without feeling pressured or judged. If they disclosed something concerning, I would listen without reacting with shock or pushing for more detail than they were ready to give. Whether or not they disclosed directly, I would follow our hospital's safeguarding protocol and report my concerns to the designated safeguarding lead or my senior nurse, since this decision should never rest on one person acting alone. I would not confront any family member directly or make accusations myself, as that could compromise both the patient's safety and any formal investigation. I would continue to treat the patient with the same warmth and respect as always, making sure they did not feel exposed or embarrassed by my concern. Safeguarding situations require both compassion and strict adherence to protocol, and acting through proper channels protects the patient far better than any decision I could make alone.
A patient becomes verbally aggressive and shouts at you in front of other patients. How would you handle it?
I would stay calm and avoid matching their tone, since responding with frustration usually escalates the situation rather than resolving it. If possible, I would gently guide the conversation to a more private area, both to protect the patient's dignity and to avoid disturbing others nearby. I would lower my voice deliberately, ask open questions about what was upsetting them, and listen without interrupting before defending myself or the team. Aggression like this is very often driven by fear, pain, or feeling unheard, so I would try to identify that underlying cause rather than treating the outburst as simply bad behavior. If they had a genuine concern, such as delayed pain relief or a misunderstanding about their treatment, I would address it directly once they had calmed slightly. If the aggression continued or posed any safety risk, I would call for support from a colleague or security as appropriate, without hesitation. Afterward, I would document the incident clearly and reflect on it with the team. Most tense moments like this de-escalate through patience rather than confrontation, and I always try to lead with that first.
During handover, you realize the previous shift missed an important observation on a patient. What would you do?
I would assess the patient immediately rather than waiting until a convenient moment, since the priority is making sure no harm has resulted from the gap before anything else. I would check their current condition thoroughly and compare it against their recent trends to judge whether the missed observation had any clinical consequence. If anything seemed concerning, I would escalate to the doctor straight away and explain exactly what had been missed and when. I would document clearly and factually what I found upon taking over, without exaggerating or minimizing the gap. I would also raise it constructively with the previous shift or my nurse in charge afterward, focusing on understanding what led to the miss, such as workload or an unclear handover, rather than assigning blame. I would suggest a practical fix if one was obvious, such as a clearer checklist for high-risk observations. Catching a gap like this is not about criticizing a colleague publicly, it is about protecting the patient first and then addressing the system issue calmly so it does not happen again.
A patient asks you a direct question about their prognosis that you are not authorized to answer. What would you do?
I would be honest with the patient rather than avoiding the question or giving a vague, evasive answer, since patients can usually sense when they are being brushed off, and that erodes trust quickly. I would explain gently that this specific question is best answered by their doctor, who has the full clinical picture, and that I want them to get an accurate answer rather than my own guess. I would not leave it there, though. I would actively arrange for the doctor to speak with them as soon as reasonably possible, rather than simply redirecting them and moving on. In the meantime, I would acknowledge their anxiety about not knowing and offer whatever general reassurance or support was appropriate within my role. I would also inform the doctor beforehand about the specific concerns the patient had raised, so the conversation could address exactly what was worrying them. Patients deserve a clear path to the answer they need, even when I am not the right person to give it, and following through on that promptly matters as much as the initial honesty.
You are pulled to cover an unfamiliar ward at short notice during a staffing shortage. How would you handle it?
I would start by quickly identifying the ward's key differences from my usual area, such as typical patient acuity, common procedures, and where essential equipment is kept, rather than assuming everything would be similar. I would ask a colleague on that ward for a brief orientation if time allowed, focusing on anything safety critical rather than every detail. I would be upfront with the team about which tasks I felt confident handling independently and which I would need support with, since pretending to be fully familiar would risk patient safety far more than admitting a gap. I would double-check unfamiliar protocols or medication procedures rather than relying on assumptions from my usual ward. Throughout the shift, I would ask questions whenever something was unclear instead of guessing, and I would stay a little more cautious and thorough than usual given the unfamiliar environment. By the end of the shift, patients would have received safe, appropriate care, even if I worked slightly slower than the regular staff. Being pulled to a new ward tests adaptability, and I have found that honesty about limitations, paired with genuine willingness to learn quickly, keeps patients safe during that adjustment.
A patient's test results reveal a serious finding, and you are the first to see them before the doctor is available. What would you do?
I would not share the results directly with the patient myself, since interpreting and delivering serious diagnostic findings is outside a nurse's scope and could cause unnecessary distress if communicated without full clinical context. I would immediately try to contact the doctor to inform them of the findings so it could be reviewed and acted upon promptly, treating it with urgency rather than waiting for a routine handover. If the doctor was not immediately reachable, I would escalate to whoever was covering, such as the on-call physician, given the seriousness of the result. In the meantime, I would monitor the patient closely for any related symptoms and reassure them generally without revealing specific details I was not authorized to share. If the patient asked directly what the results showed, I would explain honestly that the doctor needed to review and discuss them personally, while making clear that someone would speak with them as soon as possible. I would document the timeline of when I saw the result and who I contacted. Acting quickly to escalate, while respecting the boundary of who delivers serious news, protects both the patient's well-being and the integrity of their care.